What are the problems? Bacteria are among the oldest living things on the planet. They are masters of survival and can be found everywhere. Billions of them understand how important the gut flora and other body sites are for our health. The gut microbiome starts developing in the womb, but the process takes off during birth itself when babies pick up bacteria from their mother's vaginal canal and skin. Friendly bacteria living in the vagina and groin enter our body as soon as we are born. The dramatic transition from womb to world is when a baby ingests some of the first that will colonize its guts. But babies born by C-section miss out on this process and end up with a different set of bugs, including some from the hospital environment. Several studies have found evidence that this C-section microbiome could make the child more vulnerable to problems later in life. The vagina is their home, and so they take care of us until we die. This symbiotic relationship between humans and bacteria helps us stay healthy and enjoy life. Most bacteria in the environment may not be helpful or at least harmless, but few are not. Before Alexander Fleming was awarded the Nobel Prize, claiming to have discovered the miracle drug, Staphylococcus aureus fought back by developing an enzyme penicillinase that digested penicillin. Scientists with knowledge and expertise in developing antibiotics developed methicillin and other drugs to neutralize penicillin. They invade our cells, spread quickly, and cause havoc that we refer to generically as disease. Millions of people used to die every year because of bacterial infections until we developed antibiotics. These wonder drugs revolutionized medicine. But one can have too much of a good thing. Doctors have used antibiotics recklessly, prescribing them for just about everything, and in the process, helped to create strains of bacteria that are resistant to the medicines we have. We even give antibiotics to cattle that are not sick and use them to fatten chickens. Large and small companies still mindlessly market antimicrobial products for hands and homes, claiming they kill bacteria and viruses. However, these products do more harm than good because their low concentrations of antimicrobials tend to kill friendly bacteria, not viruses, and clear the way for the mass multiplication of surviving unfriendly bacteria. Perhaps even worse, hospitals have deployed antimicrobial products on an industrial scale for a long time now, and the result is a sharp rise in iatrogenic bacterial illnesses. The overuse of antibiotics and commercial products containing them has helped superbugs evolve. We now increasingly face microorganisms that antibiotics, antifungals, antivirals, or any other chemical weapon we throw at them cannot kill. Pandemics are a significant risk we run, but they are not the only ones. Doctors, homemakers, and hospital managers' overuse of antibiotics could mean that in the not-too-distant future, something as simple as a minor cut could again become life-threatening if it becomes infected. Few non-medical professionals know that antibiotics are the foundation of nearly all modern medicine. Cancer therapy, organ transplants, minor and major surgeries, and childbirth rely on antibiotics to prevent infections. If infections become untreatable, we will lose most of our medical progress over the past 50 years. And the problem is already here. In the summer of 2011, a 43-year-old woman with complications from a lung transplant was transferred from a New York City hospital to the clinical center at the National Institutes of Health, NIH, in Bethesda, Maryland. She had a highly resistant superbug known as Klebsiella pneumoniae carbapenems. The patient was treated and eventually discharged after doctors concluded they had contained the infection. A few weeks later, a 34-year-old man with a tumor and no known link to the woman contracted KPC while at the hospital. During the next few months, several more NIH patients presented with KPC. Doctors attacked the outbreak with combinations of antibiotics, including a supposedly powerful experimental drug. A separate intensive care unit for KPC patients was set up, and robots disinfected empty rooms, but the infection still spread beyond the intensive care area. Several patients died, and then suddenly, all was silent on the KPC front, with doctors convinced they had seen the last of the dangerous bacterium. They couldn't have been more mistaken. A year later, a young man with complications from a bone marrow transplant arrived at NIH. He became infected with KPC and died. This superbug is present in hospitals in most, if not all, U.S. states. This is not good. This past year, an outbreak of CRE, carbapenem-resistant enterobacteriaceae, linked to contaminated medical equipment, infected 11 patients and killed 2 in Los Angeles area hospitals. This family of bacteria has evolved resistance to all antibiotics, including the powerful carbapenem antibiotics often used as a last resort against serious infections. They are now so resilient that it is virtually impossible to remove them from medical tools such as catheters and breathing tubes placed into the body. Then we have gonorrhea, chlamydia, and other sexually transmitted diseases that we cannot treat and that are spreading all over the world. Anyone who has sex can get infected, and because most people may not exhibit any symptoms, they spread infections without anyone knowing about 1T. Sexually transmitted diseases used to be treatable with antibiotics, but in recent years, we have witnessed the rise of multi-drug resistant SIDS. Untreated gonorrhea can lead to infertility in men and women, blindness, and another congenital case of drug-resistant pneumonia. At the EuroSciCon conference in Rome, Ms. Kabukoma Christina, European African Treatment Advocate and EU, a new Europe-wide initiative that aims to enhance the quality of migrant communities in Europe, and in particular Africans living with or at risk of HIV, viral hepatitis, TB, and other chronic conditions. She explained the gravity of the problem in Italy. The influx of refugees or immigrants claiming political asylum from Asia and Africa is not only spreading HIV but also sexually transmitted infections. The young girls are said to travel knowing they will be offering sex in return for a better quality of life. I was told 15 girls, sailing across in a boat, had unprotected sex with 150 men, and so were not only infected by sharing them with others. I was surprised to see the young girls standing on the footpath and street corner during the day in sexually provocative dresses, offering sex and getting paid as little as €2. This problem is not likely confined to Italy, but must now be a significant problem all over Europe. Tourists and visitors to these European countries will likely take the infections back home and spread them in their towns and countries. Therefore, the major problem for clinicians is identifying a common symptom that may be an early sign of a significant infection that could result in an epidemic. We know that dangerous infections in any geographical area do not start simultaneously. They begin with one victim and gradually spread. However, that victim is only among hundreds of patients a doctor will typically see, so many doctors will miss patients presenting with severe infections. They will probably identify diseases that kill fast, but slow-spreading infections, such as skin infections that can lead to septicemia, are rarely diagnosed early. Also, I have seen doctors treat eczema with antibiotic cream, even though they know bacteria are resistant to most drugs. This action encourages uncomplicated infections to spread locally because patients are therefore not instructed to take other, more valuable precautions. On top of that, some people are frivolous about infections and assume doctors are exaggerating the threat, and some people are selfish. I was once called to see a passenger during a flight who had symptoms consistent with infection. He boarded the plane with these symptoms, but began to feel much worse during the flight. I was scared, knowing how diseases such as Ebola can spread. This made me think about a way to screen. Airlines must refund a traveler's ticket or issue a replacement in case of sickness, which is not the policy now. We currently have no method to block infectious travelers from boarding flights, and there are no changes in the incentive system to enable conscientious passengers to avoid losing their money if they responsibly miss a flight. Speaking of selfishness, I once saw a mother drop her daughter off at school with severe impetigo on her face. When I asked her why she had brought her daughter to school with a contagious infection, she said she could not spare the time to keep her at home or take her to the doctor. By allowing this child to contact other children, a simple infection can become a significant threat. Fortunately, I could see the rash on the girl's face, but other school kids may have rashes we cannot see. Incorrect diagnosis of skin problems and mistaken use of antibiotics to treat them are shared all over the world, and so we are continually creating superbugs. Similarly, chest infections, sore throats, and illnesses diagnosed as colds unnecessarily treated with antibiotics and often with steroids ones are also a significant threat. By prescribing antibiotics for viral infections, we are helping bacteria develop resistance and pollute the environment when these drugs are passed in urine and feces. All this helps resistant bacteria spread in the community and become an epidemic. Ebola is complicated to transmit because contagious people have visible and unusual symptoms. However, the emerging infections and pandemics of the future may not have visible symptoms, and they could break out in highly populous countries such as India and China, sending thousands of travelers all over. When infected with a contagious disease, they can expect to pass the illness on to an average of 2 people. This is called the reproduction number. 2 is not as high a number as these. Some diseases have far greater infection rates. The SARS virus had a reproduction number of 4, and measles had a reproduction number of 18. One person traveling as an aeroplane passenger and carrying an infection similar to Ebola can infect 3 to 5 people sitting nearby, 10 if they walk to the toilet. A study highlighted this a few years ago and was published in a medical journal. However, the airline industry has not implemented any changes or introduced screening to prevent the spread of infections by air travel passengers, a significant vehicle for the rapid spread of disease. It is scary to think that nobody knows what will happen when the world faces a lethal disease we're not used to, with a reproduction number of 5, 8, or even 10. What if it starts in a megacity? What if, unlike Ebola, it's contagious before patients show apparent symptoms? Experience isn't comforting. In 2009, China flu spread worldwide before we even knew it existed. This is not a simple problem, nor one that we can blame others, because antibiotic-resistant superbugs are silently spreading through UK hospitals. The General Medical Council, Royal Colleges, and the British Medical Association have not tried to help doctors immune to complaints, nor protect them from verbal or physical patient abuse. The nurse continues to diagnose infections and prescribe penicillin in large quantities because they are trained to follow protocol or guidelines and are not governed by medical ethics, do no harm. It seems that the culture of prescription and not finding a solution to the problem after listening to patients' complaints is firmly embedded in the brains of some doctors and the majority of nurses. I was surprised to see a 36-year-old patient with a history of rash, which is very itchy at night and worse after a hot bath. He had no history of rash or pruritus and demanded a referral to a dermatologist. In the last 6 weeks, numerous doctors and nurses working in family practice, urgent care centers, and hospitals have managed these common symptoms, such as eczema and infections. Still, no one has considered scabies, bedbugs, or insect bites. I have also noticed doctors working in France, Italy, Germany, and other European countries are generously prescribing antibiotics and steroids. Suppose the politicians, institutions, and leaders of medical professions turn a blind eye to the elephant in the doctor's room. Antibiotic abusers are penalized, and deaths are not centrally recorded. In that case, I will not be surprised if the outbreaks in Manchester, London, Edinburgh, and Birmingham will spread soon, leaving thousands of people dead. I was surprised because no study supports or demonstrates why one must take antibiotics for 3, 5, 7, 10, or 14 days. The CDC and other institutions recommend completing the course to help reduce the spread of infections, but this is not backed by any study or based on pharmacokinetics to prove this hypothesis. It may not be necessary to prolong antibiotic treatment, knowing bacterial infection can be cleared from the body after 3 doses. Fortunately, people in poor nations often do not take antibiotics for more than 1 or 2 days due to cost. This helps to reduce harm to the environment. Scientists have published articles proving that 1 dose of antibiotics can kill good germs in our bodies and colonize us with resistant bacteria for 6 to 8 weeks. Low-dose antibiotics, spirits, alcohol, hand wash, and antibiotic creams or drops kill harmless bacteria and help resistant bacteria flourish. Alexander Fleming's most important advice about bacteria developing resistance was ignored. He warned doctors not to use penicillin unless there was a properly diagnosed reason for it to be used. You need to know that drugs must be taken once, twice, 3, or 5 times as advised, because this is based on pharmacokinetics. Some drugs, like antibiotics, must reach an optimum concentration, good peak, to help kill bacteria. If not, the bacteria will stop multiplying, bacteriostatic, and develop resistance. If you have a bacterial infection and the antibiotic recommended is the right one, you will start feeling better soon after you take the third dose. If the symptoms are not resolved and you are not feeling better, a virus likely causes the infection, or the bacteria is resistant to the antibiotic. After taking 3 doses, the doctor must assess patients and consult a microbiologist if the patient is not getting better and not increasing or changing antibiotics. Since I returned to practice in private healthcare, I have encountered a few urinary tract infections and rashes that are not commonly poorly managed. One patient was prescribed flucloxacillin on 3 occasions in a month and also advised steroids by GPS and junior doctors working in ANI. Fungus infections like Tania are also not responding to miconazole spreading. One young pregnant woman with an itchy rash that looked like a fungal infection were advised LFT and not an antifungal drug. Common illness is common, but its clinical presentation is common. The sickness is rapidly changing, so early diagnosis and treatment are difficult. Allowing nurses and chemists to diagnose illness will not only result in complications, but death in the next few years, unless the institutions and neonates in more now act and store this unethical medical practice, identifying and preventing patients with a history of infection from visiting hospitals and surgery. Madeline Davies is a health and science reporter for the Bureau of Investigative Journalism, reported about 4 months pregnant. I caught a urinary tract infection that was resistant to common antibiotics. Doctors treated her with the orphan drug, knowing it could harm the baby. I do understand the doctors did not have any other option but to use this orphan drug. Unfortunately, these bacteria will develop resistance and spread, produce long-term problems, and are likely to relapse. Rising antibiotic resistance means people are now suffering infections for which there is no cure. They've long warned that decades of reliance on these drugs would lead to a post-antibiotic era, a return to a time where a scratch could kill and everyday operations are too risky. People and healthcare officials assume these cases are rare. However, the number of patients contracting highly resistant superbugs is rising. Infection control doctors are worried but are not acting and preparing for a significant crisis to stop this elephant in the room from going on a rampage. Carbapenem-resistant Enterobacteriaceae, CRE, live in the human gut but can cause an infection if they get into the wrong place, like the urinary tract or a wound. They are deadly and kill patients rapidly. The bacteria get into the bloodstream rapidly, and studies show that between 40% and 50% of people die. These bugs are causing considerable problems in India, certain parts of Asia, the Middle East, and some southern European countries. I must have visited a dozen hospitals in India, but no one has come forward to report they have a problem. It's easy to criticize, but hard to implement changes that they can implement. Doctors have spent their savings and borrowed money to build and establish high-tech hospitals, assuming there will be an influx of patients requiring surgical procedures. India expected health tourism to become a major contributor to GDP. Until recently, most infections were seen in people who had traveled abroad or had family members who had been in a foreign hospital. The boom in cheap cosmetic surgery in India was blamed for a spate of infections in Britain.